Hello, welcome back to the CME Academy module on breast anatomy, part 2.
We've already covered the first two learning outcomes in the CME Academy module on breast anatomy part 1. Make sure to check it out if you haven't watched the first part. In this video, we're focusing on explaining the lymphatic drainage patterns and their clinical relevance, particularly for malignancy or infection. State the safe chest drain insertion landmarks. Let's begin. Lymphatic drainage patterns of breast is of paramount importance, primarily due to its role in the metastatic spread of breast cancer, and also in localizing infections. We will start off with the patterns of lymphatic drainage of the breast. It has an extensive lymphatic network that drains predominantly to the axillary lymph nodes, accounts for approximately 75 to 80% of drainage. Most lymph, especially from the lateral quadrants of the breast and the axillary tail, drains here. These nodes are surgically and anatomically divided into 3 levels, based on their relationship to the pectoralis minor muscle. First, the level 1, low axilla. These nodes are located lateral to the lateral border of the pectoralis minor muscle. This group includes the anterior or pectoral, posterior or subscapular, and lateral or humeral nodes. These are often the first nodes to be involved in metastatic disease. Level 2, mid-axilla. These nodes are found posterior or deep to the pectoralis minor muscle. This group includes the central nodes. Level 3, apical axilla. These nodes are medial to the medial border of the pectoralis minor muscle, extending up to the apex of the axilla, near the clavicle. A useful way to remember these levels in relation to pectoralis minor is using the mnemonic loom up the axillary tree, while thinking of the muscle as a landmark. Level 1 is lateral, level 2 is underneath, posterior to it, and level 3 is medial to it, at the apex. There are other important lymph nodes other than axillary lymph node. The peristernal lymph nodes, which accounts approximately 20 to 25% of drainage. It is also known as the internal mammary lymph nodes. These nodes are situated along the internal thoracic vessels, in the intercostal spaces, deep to the anterior chest wall. They primarily drain the medial quadrants of the breast. Other minor pathways, which accounts for less than 5% of drainage, include supraclavicular lymph nodes, often after axillary involvement, interpectoral or the Rotter's nodes, located between pectoralis major and minor, or even to the contralateral breast or inferiorly to abdominal nodes. Before we move on to the next topic, let's discuss on the clinical relevance of the lymphatic drainage of the breast. Firstly, it is closely related to malignancy or breast cancer. The lymphatic system is the primary route for the early metastatic spread of breast cancer. The status of the axillary lymph nodes, whether they contain cancer cells or not, is one of the most critical prognostic factors and heavily influences treatment decisions. This leads to the importance of sentinel lymph node biopsy, SLNB. This procedure is a standard of care for staging clinically node-negative breast cancer. A radioactive tracer and/or blue dye is injected near the tumor or areola. This allows the surgeon to identify and remove the first sentinel lymph nodes that drain the tumor. If this sentinel node is free of cancer, it strongly suggests that other axillary nodes are also clear, potentially allowing the patient to avoid a more extensive axillary lymph node dissection and its associated morbidities like lymphedema. Next up, another important clinical relevance related to the lymphatic drainage of the breast is infection. An infection within the breast tissue can lead to reactive inflammation and painful enlargement of the regional lymph nodes, a condition known as lymphadenopathy. The axillary nodes are most commonly affected. The classic examples of breast infection which lead to lymph involvement is mastitis and breast abscess. Next up, the final topic of this module, we will be discussing on the safe insertion landmarks chest drain. While not directly about breast anatomy itself, understanding the anatomy of the chest wall, which is in close proximity, is vital for procedures like chest drain insertion. Chest drain is a common emergency procedure. Knowing safety landmarks is crucial to avoid iatrogenic injury. The triangle of safety is the recommended anatomical region for this. Let's focus more on the borders of the triangle of safety. Anterior border. This is defined by the lateral edge of the pectoralis major muscle. Posterior border. This is defined by the lateral edge of the latissimus dorsi muscle. Apex. This points upwards into the axilla, the armpit. Base. This is a horizontal line roughly level with the nipple, typically corresponding to the 5th intercostal space. It's important to note that the nipple line is a less reliable landmark in adult females due to breast tissue variability. Therefore, direct palpation and counting of intercostal spaces is essential. A mnemonic to help recall these borders could be palpate safe area, pectoralis major, anteriorly, axilla, at the apex, latissimus dorsi, posteriorly, and the target is typically the superior aspect of the rib below in the anterior or mid-axillary line. There are some important insertion site and technique considerations when inserting the chest drain. First, the target location for insertion is usually the 4th or 5th intercostal space, in the anterior axillary line, AAL, or mid-axillary line, MAL, well within this triangle of safety. Here's the critical anatomical rule. The incision and subsequent blunt dissection for the drain should be directed over the superior border of the rib below the chosen intercostal space. Why? This is to avoid injuring the intercostal neurovascular bundle, vein, artery, nerve, superior to inferiorly remembered as VAN, which runs in the costal groove along the inferior border of each rib, so always aim superior to the rib to stay clear of VAN. Careful palpation to identify the correct intercostal space is paramount. Incorrect placement can lead to serious complications, including damage to the lung, diaphragm, liver, on the right, spleen, on the left, heart, or major intrathoracic blood vessels.
We've covered the essential anatomical aspects of the breast. To recap from both the Part 1 and 2 video, we identified key surface landmarks like the nipple, areola, and the clinically significant axillary tail of Spence, and explored the breast's structural organization including glandular tissue, Cooper's ligaments, and the retromammary space. We detailed the arterial supply, from internal thoracic, lateral thoracic, thoracoacromial and posterior intercostals, venous drainage, paralleling arteries, with Batson's plexus as a metastatic route, and nerve supply, mainly T2-T6 intercostals, with T4 for the NAC. We explained the crucial lymphatic drainage, predominantly to axillary nodes, levels I, II, III relative to pectoralis minor, and parasternal nodes, highlighting the role of SLNB in cancer staging. And finally, we defined the triangle of safety for chest drain insertion and emphasized passing the drain superior to the rib to avoid the neurovascular bundle. This foundational knowledge will serve you well. Continue to review these anatomical relationships, perhaps with diagrams, to solidify your understanding. Well done for working through this module, and best of luck with your exam preparation.
That is the end of our Breast Part 2 tutorial. Thank you for watching.